finish in next 10 or 15 minutes. Is that okay to
Okay.
everyone?
Okay. Let's start.
Okay.
Go ahead, Irfan.
Start the, yeah. Good morning to everyone. Myself, Sheikh Mohammed Irfan from 6th year Farm Day. Today I'm going to discuss the PTC report for the month. So here is the report. Next slide, please. Yeah. A 40 years old female, the patient was in ICU. A 40 years old female who was diagnosed with CKD, LRTI, and her past history was type 2 diabetes mellitus since 2 years. And recently she had also diagnosed with hypertension. The patient's creatinine clearance was 10 ml per minute, and the serum creatinine is 9.36, which is quite high. And the patient was on tablet oseltamivir capsule. It's in 75 mg BD. And actually, if the patient is with CKD, the tablet oseltamivir requires the dose adjustment. If the creatinine clearance is more than 30, the dose adjustment is not required. If the creatinine clearance is 10, between 10 and 30, 75 mg can be advised as a single dose, or if it is less than 10 mg, 10 ml per minute, and the dose should be reduced accordingly. So in this patient, the creatinine clearance is 10, so the dose should be 75 mg OD instead of being BD. So this suggestion was made to the doctors, and as we can see on the screen here, the oseltamivir tablet which was given BD has been discontinued after the suggestion was made, and it was made it as OD. Next slide, please. There's another patient in a ward with the injection lang test, which was prescribed 2 times in the same prescription without discontinuing the one. So the suggestion was made to discontinue the drug. If there are 2 same drugs prescribed on the same prescription, so the sisters can administer like unknowingly they can administer the drug. The suggestion was made to continue. Why it was made? It was discontinued. As we can see the here on the screen, the second image, lang test was discontinued. That is, hello, Naresh, can you please change the slide?
I can hear.
There's another patient in HICU. The patient was on 3 antibiotics, and the patient had diarrhea, and the patient have passed the stool for almost 7 times in a day. As we all of us know that if the patient is on antibiotic, the common side effect of any antibiotic, it can cause diarrhea. This patient was on 3 different antibiotics, that is meropenem, metronidazole, and colistin. And the patient have experienced the diarrhea, and the patient was not on any antidiarrheal drug. So we suggested to add an antidiarrheal drug, and the drug is added. As you can see on the screen, the tablet Sifolac DT was added for the patient. Next slide, please.
Abba.
This patient was again in HICU. Unauthorized drug was seen in the patient bedside. As we can see, this nitrofurondine capsule, which is not been prescribed in the prescription, but it was found in the patient bedside. This can lead to some wrong administration of the drug. Nurses may administer the drug without, like, unintentionally. So this suggestion was to remove this drug or to make use of a red pouch. This was informed and it was removed from the patient bedside. Next slide. This patient in ICU again, the patient with hypertension was on bisoprolol, which is a beta blocker of 2.5 mg OD, but the timing was mentioned OD, but by mistake the doctor had written 8 a.m. and 8 p.m. BD in the timing column. So the suggestion was made to the nurses to make it as OD. As we can see in the frequency chart, the frequency is written as OD, but in the timing chart, it is written as BD, 8 a.m. and 8 p.m. After the suggestion was made, the 8 p.m. was being cancelled and it was made as 8 a.m. only. Next slide, please.
Timing will be
Dinasri
written
rest
by nurses.
Yes, sorry.
Like the dose and things will be written by doctor. Timing, what you said, 8 a.m. and 8 p.m. will be written
Yes.
by nurses. It is a nursing error.
Yeah, that's what. Then this was informed to the nurse and it was made as 8 a.m. only. Doctor had to set as OD, but unfortunately by mistake they have written as 8 a.m. and 8 p.m.
Okay, fine.
Clear, Vinu?
Sir, just a small doubt whether nursing error will also be presented or it's only the other
Yeah,
things.
all.
All
We
the
are
errors.
even quality department will be sitting. No, they'll be looking holistically. It's not only doctors or nursing. Okay. Even some
Okay,
kind of incompatibility. Some, for example, oseltamivir, we have only capsule formulation. We don't have syrup formulation. Though it is not the mistake of
Syrup is there in
doctors.
oseltamivir.
Pardon? Syrup
Yes,
again?
yes.
Syrup is there. If the dose, if the dose
Syrup.
adjustment is required less than 75 mg, we don't have any other formulation
Previously
less than
we didn't
75
have
mg.
syrup actually. Now they came
Yeah,
because of
yeah.
we
Yeah,
intervened many
pediatric
times. We
population.
presented many times in the PNT meeting. We insisted that okay, those had to be adjusted for oseltamivir. So they brought in the syrup as well. So this was neither a mistake of nurses nor a doctor because the formulation was not available. Even the doctor was helpless. So
Yeah, correct.
because we presented this scenario many times in the PNT meeting, they came up with the solution bringing syrup. So it's not only that physician or nurses mistakes or error that we present here. It's entire thing. Okay, all about quality.
There is one more interesting point to know about the oseltamivir, as it is now made as a syrup form. In each tablespoon of syrup, oseltamivir contains of 30 mg oseltamivir drug. So according to this, we can manage the dose of the patient, like how much amount
See,
of drug.
move the slide back to the oseltamivir. When you're talking on something, let the same slide be. You're talking about the previous slide?
The first slide, sir. Oseltamivir. No, it's not finished, sir.
Okay, so do not mix it up. This it causes a bit
Okay,
of
that was the old
confusion.
thing. But since she asked, can we present only doctor or nursing error? So I just took the example of oseltamivir to explain that it's not only nursing or doctors, but overall thing. The oseltamivir came
See,
in
in this meeting, so here any errors, maybe from prescription error to therapeutic interventions, anything that you find something unusual, inappropriate, then anything from even from the capital letter, use of abbreviations, okay, contraindications, any kind such of anything that is there, we can present here. There is no restrictions for only this kind of things we have to present.
Yes, sir. Also the drug-drug interactions.
Yeah, drug ADRs. So
Go ahead, Irfan.
Here is the next. Yeah, here is the next slide. So another patient in ICU again. The patient with angina, which is a chest pain. The patient in the medication chart, the patient was written as a tablet ticagrelor 90 mg per oral OD. Actually, it should have been BD instead of OD because the ticagrelor is normal dose of ticagrelor is 90 mg BD. According to the guideline, it should be BD only. Here it has been prescribed BD only, but in the frequency they have mentioned OD, and the timing they have mentioned 9 a.m. and 9 p.m., which is correct. The frequency they have mentioned OD, which is wrong. So this was brought into the notice to the doctors, and they have made it as BD. They have not changed the timing here, but they have changed the frequency from OD to BD.
Okay.
Can everyone see this? Ticagrelor. Yeah. Next slide, please. This one. This is again in HICU. This is an untreated indication. The patient's magnesium level was low, which was 1.6. So this was not treated, and nobody had also observed this one. This was brought into the notice of the doctor, and they have added this injection magnesium sulfate, MgSO4, in 100 ml NS. Can you see this in the right side image, injection MgSO4 was added after the suggestion was
Oh,
made.
what was the potassium value?
Potassium value, they have not recorded that one. I've only focused on this magnesium.
But the potassium in this kind of patient is important. If one, as Sarath rightly asked, there are some conditions, some cases where you correct the magnesium, the potassium itself gets corrected. So there is a relationship between magnesium and potassium, and even the patient is on lacilactone, okay, and prednisolone. So all these things can affect potassium too. So
The patient is on syrup potassium chloride also in the medication chart.
Yeah, I can see this in the
so the
left
potassium
side.
becomes
Yeah,
important in
syrup
this case.
potassium chloride is there.
Yeah, we can
Maybe
see
the
here.
potassium could also be in the lower side. So only
Yeah.
they have started with the potassium as well as the magnesium sulfate.
That's what sometimes this resistant hypokalemia, okay, and resistant cases of this potassium abnormality will respond to this magnesium supplement. Okay.
This is in ring 5. The patient's PT level, APTT and INR was changed, was altered. So the suggestion was made to add a vitamin K injection. If the patient was not on vitamin K injection before, after the suggestion was made, the injection vitamin K was added. As you can see here in the image, vitamin K is added. Next slide. This is in wing 4 again. Tablet like linezolid drug was supposed to be discontinued after the day 5. According to the prescription, the linezolid has prescribed for 5 days only. You can see here day 5. They have crossed 5 times, like 5 doses, but they have not discontinued that drug. The next day, 6th day morning, also the sister had administered the same drug to the patient. It was supposed to be discontinued the last day, 5th day only. This was brought into notice and it was discontinued at the same time. Next slide, please. This is in ICU. Injection pantoprazole, and this is a drug-drug interaction. Pantoprazole and levothyroxine, which are given at the same time at 6 a.m. in the morning. As we all of us know that pantoprazole has to be given at 6 a.m. in the morning, as well as the levothyroxine. But there is a drug interaction between these two drugs. But the levothyroxine will act only in the acidic condition, and the pantoprazole will inhibit the acidic condition, like acid production. So this efficacy of the levothyroxine will reduce. So every time, whenever the pantoprazole and levothyroxine is to be administered at time, so there is a 4 hours gap. We need to maintain at least 4 hours gap after the pantoprazole is given. So this suggestion was made to the doctor, but they have not made 4 hours gap. They have made only 1 hour gap. Pantoprazole is being given at 6 a.m. in the morning, and this one is given as 7 a.m. levothyroxine.
There's one thing, sir. Many consultants say that about the next dose, like when we give a gap between pantoprazole and levothyroxine on the first day,
Yes.
the inactive hydrogen potassium ATPase channels also play an important role when we give the next dose. So how can we?
But the next dose is given in the next day only, no?
No, but the inactive hydrogen potassium ATPase channels will get activated by that time.
See, if you remember during my class when I was teaching you drug interaction, I had told you you cannot avoid this interaction completely, though by spacing. Though you will space 1 hour or 2 hours between these two drugs, you cannot avoid this 100%, because you know that once this pump get inactivated, this pump takes again next 24 to 48 hours to to synthesize new pump, and then the acid secretion starts, isn't it? So anyway,
Yeah.
you have given a PPI, pantoprazole, and the pump is inhibited. So it will take another 24 to 48 hours to for the new pump to produce, to synthesize, and then the acid will start secreting. But here, many things you have to consider about that pump. Number one, 1 dose or a 2 dose or a 3 dose of PPI, how much pump is getting blocked with that initial couple of doses or with that initial 4 or 5 doses of PPI, number one. Number two, when you give the next dose of levothyroxine followed by pantoprazole, when you are giving, for example, first dose the patient received today morning, okay, first dose of PPI. Now, as as the time passes by, for example, today morning he received, and by evening, 6 p.m. it becomes 12 hours. By tomorrow morning, it will become around 24 hours. So by that time, okay, but till this many time, and the pump will be kind of again in the process of regenerating, because it is already more around 12 hours. So so that time there is not much suppression of acid as compared to today morning. So tomorrow, before next dose, just before next dose of pantoprazole, if you give levothyroxine, definitely there is the least interaction between these two drugs. But instead of that, if you give levothyroxine after the pantoprazole next day, then that's completely the definite sure way of making these two drugs to interact. Are you guys following me?
Yes, sir.
Yes,
You
sir.
guys got what I mean?
Yes,
Yes,
sir.
sir.
So
Yes,
though,
sir.
so though we are not
Yes,
able
sir.
to counteract here 100% of the interaction, we are not able to resolve, but at least to a significant amount we are reducing by making the levothyroxine first and then giving the pantoprazole. So this also explains the reason why do we give levothyroxine before than pantoprazole. Okay. So many times we see patient on multiple drugs taking at different timing, and we don't use our concept to understand, okay, why this drug first and why this drug second and why this drug third in the order. So this also explains the order why we need to give levothyroxine rather than pantoprazole. Okay, if it is only the matter of spacing, some people may argue, okay, let's give pantoprazole morning and let's give the levothyroxine 4 hours after that. But that won't work, you know that, because once the pantoprazole will block that PPI, it's gonna be blocked till again next 24 to 48 hours. Are you following? Did you get it? What I mean?
Yes.
Yes, sir. Yes, sir.
Yes, sir.
Okay, I hope I addressed the query.
Sir,
Anything?
sir, and one more thing with iron arm,
Yes.
when written